What about the role, before we get into more metastatic disease, what about the role if people have oligometastatic disease on presentation? Pulmonary metastatectomies, is these things you do? Do you try to clear a patient of disease if possible, the primary site and other sites? What are the thoughts on that?
I think, so the topic of oligometastatic disease is complicated. And I think you can have a patient who presents de novo with oligometastatic disease, or you can have a patient who's had their primary addressed and then they develop oligometastatic disease at some point in the future. To me, those are two different scenarios. For a patient who presents with oligometastatic disease de novo and their primary hasn't been addressed, I think to the comments that were made earlier, a multimodality approach certainly is reasonable. That would be a situation in which I would consider chemotherapy, and then after chemotherapy, resecting, if able, the oligometastatic disease. For a patient who presents separately, let's say a couple of years after the primary is addressed, I would treat that with surgery alone. But I think it's certainly a patient population where, for the right patient, being aggressive and rendering them with no evidence of disease has potential for long-term benefit.
Does everyone kind of take the same approach? If you can make a patient disease-free, take that?
It's all about biology.
Yeah.
Right?
Yeah.
If this thing is blowing up and the tumors are growing quite quickly, I would not put them through a surgery. I think we need to figure out whether we can get control, because otherwise you're playing whack-a-mole, right? You take one out and something pops up quickly. Yeah. So, but we all have these patients. They have metastatic disease that pops up once a year, once every 2 years, and you take it out, and they're trucking along for many, many years, right, with really just taking out a couple of surgical without even receiving any systemic therapy. And they do quite well, right? But we need to be able to distinguish those from those that actually are going to be really having aggressive disease or not going to benefit from surgery. Right.
But also putting patients through surgery every 6 months for pulmonary nodules doesn't make any sense. So we've been doing a lot of ablations, microwave ablations, cryoablations, so maybe a little bit of focused radiation, So patients have been doing really well. I mean, I have patients 5, 10 years later, every now and then we just have to zap a little thing, so that's also an option for those patients.
I agree, and that includes your disease management team is always engaged throughout care. Even when you're really pushing chemotherapy, there are times to really engage them and say what procedures may be available, what's the cost of the procedure, the timing, and the cost in the sense of what patients go through, the timing, what's the goal of the procedure. Yeah.
And I think there's an aspect of the biology to add on to Victor's statement, and that's the chemosensitivity of the tumor. And so when we see a patient with oligometastatic disease, it's metastatic. And so we generally, in most cases, especially if there's a fast growth rate or the metastases have shown up in less than a year, then we would consider chemotherapy with either doxorubicin plus Olera for metastatic disease, based on the data that you've published, or doxorubicin ifosfamide. Or there's a very compelling phase 1 clinical trial of doxorubicin plus ifosfamide plus Olera.
Yeah. I think these are all emerging data.